Quickly, I would run through the challenges in ovarian stimulation in cancer patients. First, it is the risk of what is exactly the risk of ovarian failure. As we know, in cancer treatment, it depends upon mode of cancer treatment, that is either chemotherapy, radiotherapy, or any surgery, dosages of chemo and radiation, as well as the age of the patient and ovarian reserve at the time of the cancer diagnosis. And as we know that the basic step for oocyte cryopreservation or the embryo cryopreservation, which are currently the most established strategies for the female fertility preservation, is controlled ovarian hyperstimulation. So of course I am not discussing this in detail with the fertility perspective, but as a oncology perspectives, what we should be aware about, that I'll just mention few points. So the prerequisite here is counseling to the patient and the family members, and actually to assess the ovarian response with respect to the tests like blood test AMH and the ultrasound telling about the antral follicle count, which helps us to decide the stimulation protocol and the dosages of gonadotropins. But it is very important to have the discussion about the expected response. That is important in the counseling. And most important goals in this control ovarian stimulation, especially in the fertility preservation cycle, is minimum duration. That is very, very important, because here our focus is the cancer treatment first. At the same time, we need to have the maximum good quality oocytes, because again the time constraint, we can't go for the multiple cycles, as well as minimize the risks, that is most common complication, that is ovarian hyperstimulation syndrome. So what is different just because of the cancer? So first is, yes, because of the cancer, because of malnutrition, high catabolic state, as well as the raised stress hormones, definitely the function of the hypothalamo-pituitary ovarian axis is affected, leading to the decline in the fertility, as well as it reduces, because of which it reduces the response to the stimulation. We might require higher dosages of the gonadotropin, and especially certain mutations like BRCA, which is it affects the oocyte with respect to the DNA damage. They are more prone because these genes basically involved in the DNA breach repair. And definitely we have these two stimulation protocols with us, GnRH agonist and antagonist. I don't want to go in detail, but focus is here we use mainly GnRH antagonist based protocols, which reduces the complications like OHS's hyperstimulation, and which gives us the maximum oocyte yield with the minimum duration. So here just let me tell you, because there are still myths, like suppose we have like a case of the say breast cancer or other things, can we go ahead with the stimulation? Or patient is coming to us, she's not in her second or third day of the menstrual period, then do we really give the option of the fertility cryopreservation? So these are the myths. So I just want to discuss that. So that's why I have put some clinical scenarios, like here 25-year-old married female. So married female, so definitely we have the option of the embryo cryopreservation, and she is currently on oral contraceptives. She has been diagnosed as a sarcoma. Of course, the plan is a surgical resection followed by chemotherapy. So we have within a month. So this we have got from the oncologist. So we have 1 month's time, and she is currently on oral contraceptive pills. So definitely the option opted after discussion was embryo cryopreservation. And then what we have to do, so this is something called early follicular phase stimulation with the antagonist protocol. That means what? Here we have got 1 month of time. So depending upon the duration of the OC pills she would have taken, so at least after 14 to 15 pills we will stop the OC pills. Then once within 2 to 3 days of the withdrawal bleeding, we start the stimulation and we go for the protocol. So this is a very simple thing where we have got little time with us, and then accordingly we can go for the routine stimulations. Of course, I'll not go in detail of this, but yes, this is one kind of scenario where we have got little time. Then the next scenario where it is like 27-year-old married female, currently at day 11 of the menstrual cycle. Okay, so not in the early follicular phase. She is diagnosed with a hematological malignancy, and of course hematological means we have to start chemotherapy as early as possible. And because they have chosen a fertility preservation option as an embryo cryopreservation, so how we can do? So this is like something late for a random start. That means we don't have to wait for her periods or other thing. Definitely we immediately comes to us, she picks up the option, we really need to go for the stimulation. So this is also available nowadays, which is called as random start approach. So initial which we saw was the conventional, and now this is the random start, and it has been proven that with the both options, the comparable oocyte retrieval, maturation rate, and the further success rates of the therapies, it is of course comparable. So these are details, I'll not go into that. Now another important scenario, another interesting one is 21-year-old unmarried girl, currently at day 25 of menstrual cycle, so little late, and she has 30 days of the regular menstrual cycle. She is not on any pills. She has been diagnosed as Hodgkin's lymphoma, so of course chemotherapy has to be started as early as possible. So she is unmarried, chosen option is oocyte cryopreservation. So we need to go for the stimulation now. Here, of course, there is something called then luteal phase stimulation. So this is also possible. So this is one of the random start stimulation. So here, oncology point of view, I just want to make one point that whether female is in the menstrual cycle or not in the actual cycle, so at any phase, so as we know the basic phases, early follicular phase, late follicular phase, or the luteal phase of the cycle, any time we can go ahead with the stimulation with a comparable and good results. So that is one point I wanted to make. Another very important point here is another case scenario where 31-year-old married female, estrogen receptor positive breast cancer. Again, then it comes like, oh, estrogen sensitivity, estrogen receptor positive. So can we go ahead with a high estrogen states? Of course not. So definitely the plan of treatment was mastectomy, followed by chemotherapy, followed by tamoxifen, and surgeries to be planned within 4 weeks. Sorry. And the option chosen was embryo cryopreservation. So here comes a strategy called Letrozole based stimulation protocol. So anytime, as I said, any time of the cycle we start the stimulation, but to keep the estrogen levels low during the stimulation, this is the Letrozole. As we know, it is the aromatase inhibitor, where it will keep the estrogen levels throughout the stimulation cycle as low as the natural cycles. So that is very effective drug, and it can be started basically as soon as we start. Basically it started the first, and 2 or 3 days later we start the stimulation, and we go ahead with the antagonist based protocols. And this also letrozole is continued even after the stimulation. So to reduce the estrogen levels faster, we can even continue the antagonist after the even egg retrieval. That is very important. So we have got letrozole, which is a magic drug, which is very important for the estrogen sensitive tumors, even estrogen like even endometrial carcinoma. So this is very important. And one more point, there are some special considerations when we are going ahead with the procedures like oocyte retrieval. Like there can be a risk of thromboembolism because of the hypercoagulable state, which can be because of the cancer or high estrogen levels. Of course, there can be risks of bleeding because of thrombocytopenia in the hematological malignancies or platelet dysfunction. We need to tackle that, sometimes giving of course FFPs and platelets for the thromboembolism. Sometimes we can cover up the procedure with the low molecular weight heparin. Then there are risks of infection because of the neutropenia, so we need to cover up with a good antibiotic cover. Then anesthesia complications are common. Then we need to also consider certain medications, like for example anti-epileptic medications has to be continued because it has a risk of the seizures, especially in the brain tumors. But certain medicines like imatinib, which is used in the CML, that has to be temporarily stopped, but of course with the oncologist consent, that because it will have a adverse impact on the oocyte recovery and oocyte yield. At the same time, certain things like IV line placements to the upper extremities on the same side of axillary node dissection, that should be avoided. Then sometimes patients who have had the transverse rectus abdominis flaps for the breast reconstructions, they might have some problems like if the OHSS happens, because it leads to ascites, abdominal distension, might lead to wound dehiscence. So these are certain complications we should be ready with. So we should have the well-equipped anesthesia team, intensivist team, medical team who can deal with such a kind of complications. So just to summarize, determination of controlled ovarian stimulation protocol and gonadotropin dose for oocyte and embryo cryopreservation requires individualized approach, and maximizing the number of the embryos and oocytes cryopreserved during the fertility preservation cycles without causing OHSS, without any complications, is very, very important, because most of the patients will have only one cycle opportunity because of the time constraints. And in the urgent settings, we can use the random start protocols, which is a emerging new technique for the purpose of the fertility preservation cycles without compromising any oocyte yield and maturity. And very important is letrozole plus gonadotropin protocol is very effective and safe for especially the patients having estrogen sensitive cancers. So with this, I summarize my talk on the ovarian stimulation.